be having Emily and Dan with us to share their practice and reflections while they were conducting their HARP evaluation project. So welcome to you. Before we start the presentation, I would like to inform you that this webinar will be recorded and will be later uploaded to our YouTube site, Coventry HDRC YouTube website. So just to let you know of that. We will be listening to the presentation first, and after the presentation, we should have 10 to 15 minutes for questions. So you will be able to ask any concerns, any questions to the presenters. So I will hand it over to Dan and Emily then.
Brilliant, thank you, Eve. Good afternoon, everyone. It's a real pleasure to be here. I don't know from the audience, I recognise some names. Myself and Emily gave a presentation of the HARP findings in person in Coventry back in October. At the end of the project and at the report delivery, we've changed around some of the bits and pieces today, so hopefully we're not getting a duplication of what you've already talked about. But as Eve said, we're here to talk about the evaluation of the Health Access Refugee Programme, which ran in Coventry from the end of 2023 up until the end of 2025. We were involved as formative evaluators in that project from the beginning until the end. So we worked with the project to help refine and shape it as we went. And we're going to sort of talk through the methods we used and the findings we had as we go today. So by way of introduction, I'm Dan Range. At the time of the HARP evaluation, I was an assistant professor and director of learning development at Coventry University at the Centre for Trust, Peace and Social Relations. And Emily worked there as well as a researcher. We've subsequently both left Coventry University and co-founded the Centre for Inclusive Evaluation. So we now sort of run the Centre of Inclusive Evaluation to conduct evaluation just like these, where we work with stakeholders and participants across the whole spectrum of a programme to really collect those robust, holistic data sets that show the impact at very grassroots levels, up through organisations and into the sort of structural levels. Emily, do you want to expand on that?
Yeah. So I'm aware that for the last sort of lunchtime learn session that was run by Coventry HDRC in January, Angie was one of the presenters. So Angie was running the programme from Coventry City Council side, and so we're going to talk a little bit about the programme, but not in too much detail in terms of what they actually delivered, more focused, I guess, on the research that we conducted as a part of the evaluation. So Health Access for Refugees and Asylum Seekers ran, as Dan said, for 2 years. And during that time, they worked very closely with 3 community connectors from 3 grassroots organisations within Coventry to prioritise health interventions. So not specific primary health care, but support for refugees and asylum seekers that were already accessing support in Coventry for a variety of different needs, but bringing health concerns and, I guess, addressing health barriers and needs into that space. The importance of independent research and evaluation, I'm sure for those of you that have attended HDRC webinars before, it will be very familiar, but we really value at our organisation and want to work with others that value this is embedding that practice-based research. So taking the time to ensure that you give good evidence and have robust research involved in projects that are delivering, not just limited to health, but within health as well. And particularly this project appealed to us because it was exploring health inequalities and how local systems learn. Myself and Dan have done lots of work over the past few years, particularly with local authorities, around how you get the most out of your projects, and particularly where those projects have to be evaluated or have evaluation, making sure that that independent research that's done for an evaluation is really useful and impactful moving forwards.
Thank you. Oh, this is an ugly slide. You can tell where I've done the editing rather than Emily on these. So we wanted to just link the relevance of the HARP programme to Coventry HDRC. Obviously, we know the linkage to there. We suspect most of you do, particularly if Angie spoke at the last event and you were there. But HARP was really, really clear from the very beginning in attempting to address those social determinants of health, and really did have a strong focus on the structurally vulnerable migrant community. So it didn't recognise, a lack of healthcare always as being sort of a particularly always personal issue. It would linked it very strongly to those structural issues, and really avoided the use of the word hard to reach and so on, the words we tend to avoid using as well. So it recognised that there were barriers within society and within organisational structures in and around Coventry, which are pretty true of the rest of the country as well, which made particular communities with particular intersectionalities much more unlikely to be accessing healthcare in a way that healthcare sees itself often as being accessible in the UK. In line with the ethos of the HDRCs, there was that real effort. There was a real effort to have evaluation built in that very formative way. So this wasn't a monitoring exercise. We'd probably been a lot less keen on engaging with it if it was a monitoring exercise. It was a learning tool, so we could work formatively with the programme to help shape, refine, and improve delivery as we went through. And a key ethos of that was co-production. So it was more challenging to get participants involved throughout in co-production because of the sort of often transitory nature of people. You often had 1 or 2 engagements with people, but partners and the partnership were really well engaged in shaping the tools we used and the framework around doing that. So this was all focused on moving away from just learning on an individual project sake and learning more about system change and system values. So what is transferable and generalizable, rather than saying something worked just in this specific instance. And that links into the research around the building blocks of health and HDRC targets around, or specific key thematic areas around transport, local economy, housing and homelessness, digital inclusion, employment, skills, and the best start in life. I mean, we saw those coming up over and over again in the work that the community connectors and the other partners on the project did. They were a real focus to different degrees, but they were a real focus throughout.
So in keeping with us talking a little bit more about the research rather than just about HARP, I'll quickly go through the methods. I know we maybe didn't say at the beginning, but there is an opportunity for question and answer at the end. I don't know whether that will be in the chat function or whether people will be able to unmute themselves. I don't know. I'll let Eve step in when we get to the end. But so I'll give a quick overview of how we approach the project, I guess, in terms of our data collection. So as with most of this work, there was mixed methods elements. So we had qualitative data collection, which was where we went in and spent time with the project. So get really close to the project, both through formal interviews, observations, focus groups, narrative reconstructions, but also through some of the more informal methods where we spend time with delivery partners and stakeholders so that we are familiar and known, and we sort of participate as far as is possible, where we're getting involved, we're helping with these organisations. When we're in the room, we're not sort of just sat in a corner not talking to anyone. We try to engage, and if, for example, I was attending a nursery play session, I would be helping with the organisation that was delivering. I wouldn't just be sat and extracting people to go and talk to them. It is something that takes a significant period of time. Like, you don't just go once, you go several times and spend as much time with that project as you can, so that you can get to know the people that are involved and build the trust that allows you to conduct meaningful research with people rather than at them.
And as a practical example of that, I ended up being the person who got put in a recovery position over and over again at a first aid for English, first aid for ESOL training course. So I spent most of the day rolling around on the floor. That's a really good way of building rapport with participants.
I think also important to that is we operate from a lens of cultural humility. So our focus is on making sure that when we go into spaces, we appreciate that we don't know what's going on, which sounds obvious, I would like to think, but actually we take our lead from all of those partners that are involved before we go in with a research mindset. So we spend a lot of time working with delivery partners, particularly talking to those organisers at grassroots organisations, so that when we go in, we're not causing disruption, that people are comfortable with us being there, and we're not going to negatively impact any of the work that's going on, particularly where some of it is sensitive and around health. So within that is the ethics that we work to. So we work to university standard ethics around research, lots of things included with that. But the best sort of examples I can give is that there's transparency with research participants and those who are involved in what we're doing. So we're letting people know ahead of time what we're doing, who we are, why we're collecting information, and also giving people the right to refuse to engage. So at any point, if anyone chooses not to engage with us, whether it's in the moment of data collection or afterwards, we make sure that our contact details and everything are available so that we can honour that commitment. Also, anonymity for participants. So if people do decide to be involved, we make them as anonymous as far as possible. So by taking out any identifying details or trying to make sure that where there's trends across the partnership where you're giving that evidence, you're making sure that it's as anonymous as possible. Trauma-informed approaches, so particularly when working with vulnerable groups, ensuring that when you're going into those spaces, you're doing no harm. So what you're talking about isn't going to be at risk of re-traumatizing people, working really closely with organisations to make sure that we're not springing anything on anyone. Nothing should be coming as a surprise, and that everyone has full opportunity to either participate or withdraw from talking about the areas that we're there to talk to people about. And then as a part of that co-production, it's not just the method. So it's not just us discussing with the communities that we're working with what the best approach is or what they think is most appropriate for their groups, but also the learning framework. So within an evaluation, you're looking for the successes of the project. And to do that, we work to a theory of change model, which we start at the beginning of any project with the people that are involved. So that will, depending on the setting, include stakeholders, partners, beneficiaries. But for this particular project, Dan will talk through how that evaluation model works for us. And please don't be off put by the very tiny diagram. It's more the shape of it, so that we can now talk you through how it works for us.
Yeah, brilliant. Thank you. Yeah, I was going to give the health warning about not trying to squint too much to read the writing here. We will make sure the slides get sent around, so you will have a sort of chance to zoom in on this. But this is the co-produced theory of change model for HARP. And it's informed the evaluation framework that we used throughout the programme with some sort of minor revisions. So this was co-produced early in 2020. I'm trying to do the years here. Early in 2024. So sort of just as the programme was passing through the inception phase and kicking off, it was a full-day session hosted by myself and Emily with representatives from all of the partners. So we had people from Coventry City Council, the Free Community Connectors, and Coventry City Football Club there, as well as people who had lived experience via those organisations of accessing healthcare in the UK as a refugee, asylum seeker, or recent migrant. So we really wanted to get that sort of full picture of perspective to get the language right. To start the process, we spent sort of an hour or two discussing what the actual aim of HARP is, and that always throws people out a little bit, because everyone has sort of signed up to deliver on a project. Everyone kind of thinks they know what they're doing, but everyone phrases it differently, right? And everyone puts different focus on different bits and pieces of it. So in a room full of, I think we had sort of 20 or 22 people for this session, we got lots of different variants of health outcomes, refugees and asylum seekers, different areas, different geographic areas, different ways of saying it. Employment crept in there, independence crept in there, and so on. So we sort of talked around to try and get that language right, so everyone from the start of the project is focused on the same goal and using the same language. That, in our experience, is really, really important in complex, multi-partner, multi-stakeholder projects. And eventually we got it distilled down to improved health outcomes in refugee and asylum seeker populations within the Coventry area. So geographically specific, we're working within the Coventry area. Who we're working with, refugee and asylum seeker populations, and what we want to see, which is improved health outcomes. Yeah. So we got that distilled down, and then we looped right down from that aim at the top. We looped right down to the activities at the bottom. So we asked everyone in the room to take a bit of time to list everything that they know that the project does, or that they do as part of the project. And that was an hour or so of working as individuals and as groups, and we got lots and lots of post-it notes and lists from people, like dozens and dozens, maybe even 100 activities. And then we sent everyone away for an hour, and we went through sorting those by what they aim to achieve, right? Not when they happen in the project, not by who does them, but by what they aim to achieve. And in that way, we sorted the project into 6 different activity bundles. So we had at the bottom there, from left to right, we've got education, training and awareness, advice and support, advocacy and outreach. So these are the 3 things which the project did, which really worked directly with the clients. Then moving across, we've got promoting access and removing barriers, building and growing the partnership, and internal HARP development. So these are the bits which were much more focused on building capacity and building towards structural change. So building towards changes in behaviours and attitudes of organisations. And all through from there, we was able to do outcomes, right? So all through this, those outcomes we have there are all directive. We're looking at there being more of something, less of something, greater, fewer, better, worse, anything which we can measure in a directive way, which shows the program is working as we expect it to, following those arrows, which are assumptions, or where we can then say the project isn't. So, we would assume that if all that activity around education, training and awareness raising takes place, the first assumption would be that there's more education and learning materials on relevant health issues in Coventry for refugees, asylum seekers and healthcare providers. Right. So we assume that if you produce materials, there are more materials. We then assume that if you produce these materials, that people will access the appropriate services, healthcare and healthcare providers, and that there'll be a better delivery of appropriate services. So they come up quite incrementally in what they do, and we were able throughout the evaluation to put qualitative or quantitative measures on these, and where things weren't working, where the assumptions weren't following through, where we didn't see say improved partnership working leading to more funding and support, we were able to challenge that and ask why, and to sort of loop back to where the blockages are. So that's the evaluation framework we use. I could talk about this all day, so I'm mindful of not waffling, and Emily's making quite aggressive eye contact with me at the moment.
So the next section to look at was our HARP client. So Dan led largely on the quantitative data, so I shall let you take this one.
Okay, I'll do this one slightly quicker. To start with, the HARP clients were massively interesting and diverse, right? Coventry is a big city by UK standards, population of about 350 odd thousand people, but it's not a huge city, right? Over 2 years, through the 3 main community connectors and Sky Blues in the community, we saw at least 1,588 different participants. I say at least because we know that we mainly Emily attended a lot of sort of mothers and babies clinics and stuff that had lots of nursery age children and toddlers getting access to services and access to provision. But then when we look at the data, there were very few children recorded, right, because the parents are recorded. So we know there were a lot more than the 1,600 or so participants involved. We also know that there were a lot more than 5,204 engagements. That figure was against a target of 4,500 engagements. We know that there were a lot more than that. And those figures themselves are huge. Over a 2-year program that wasn't multi-million pound in its scale, to target these very often isolated, very transient groups, to get people engaged on this level was a real achievement. And again, in a city that itself isn't huge, to see at least 74 different countries of origin and 53 first languages recorded is massive. Like, the level of need there is in Coventry, the diversity within that need, and the ability of the community connectors to respond to that in a way that met it is fantastic. I don't think you get that ability to work with people from 74 different countries of origin or 53 first languages just by working through statutory providers. This is where you do need those linked in grassroots communities with people with lived experience and who have those first languages or have access to those people who do have those first languages. The last one there is that 72% of participants were refugees and asylum seekers. The programme was, it is HARP. It was aimed at refugees and asylum seekers, but it had a policy of not turning other people away. Turning people away from programmes is divisive. So where there were recent migrants who arrived in the city, they were able to take part in the programme too. And there were lots of gaps as well around who is a refugee or an asylum seeker. So an education for me was that Ukrainians don't count as refugees or asylum seekers because they are here on visas. And similarly to British national overseas, mainly people from Hong Kong, they don't fit neatly into a box either, but they were welcomed into the programme and were
sorry, by HARP offering that protection to those who are under humanitarian protection measures, it gave those community groups that are already working to serve such diverse communities greater scope. And I think for them as well, largely speaking, it tended to align more with their ethoses around who and how they support, and that they're there to support everyone in their community that's in need, which was a real benefit of this project being a pilot and being able to, we'll come to it sort of later, respond quite agilely in the work that they were doing.
Yes, I think the message there from us would be, if there are any people who are funders of programs like these on the call today, or anyone who's listening at a later date, think about the organisations you're working with and who they work with and the position it would put them in to turn people away. Mm-hmm. And think about the sort of mess that international politics have been and world affairs have been for the last 5 years. And if you're commissioning a programme tomorrow to start in 6 months to run for 2 years, what could happen in the next 3 years? You don't want to pigeonhole who the programme can and can't work with. You need to build that flexibility and agility in.
We've got we've broken the findings down into 3 main sections and how they affected the different levels of engagement or the different stratas of people that were working on the programme. But we recognised that was probably quite in depth and didn't really cover the overall evaluation findings for the fact that HARP was a pilot, and that as it ran, as we've written on the side, it was incredibly successful, both as a project in its own right, but also as a proof of concept. I think the agile and innovative nature of HARP for us as researchers is really interesting. Like, what we were looking at, I don't want to say was constantly changing because that makes it sound like everything was always in flux, but what actually happened was that when things were not working or where things needed to change, they were so responsive. And it meant that as evaluators, what we were submitting as evidence or what we were finding was being worked on. So it goes back to that sort of research in practice and research being impactful. As we took the opportunities to gather data, collect that feedback and engage with the council, it was also then used. So what we were getting to see was how innovative this pilot could be, and in trialing different types of work. So for example, they were finding that there was quite a lot of early healthcare intervention need in the asylum hotels that were in and around Coventry, and that this programme managed to take that information, work on it, and develop their own health clinics that ran within the asylum hotels, and that wasn't necessarily something they'd imagined at the beginning of the project when it had started, but as it became apparent it would better serve the communities they were trying to work with, it was something they were able to adapt to and run with. And it was really, really agile in its way of working. Over 2 years, they achieved so much, really. And I think, as Dan was saying about those numbers, it became quite evident in the amount of people they were then able to reach. It was well run and it grew in capacity. So I think something that we'll talk about was sort of the passion that everyone involved had. I think it probably makes sense. Most people that are working with asylum seeking and refugee communities and are willing to sort of take a healthcare stance, there's quite a lot of passion for everyone involved, both for people that initially came from a healthcare background, becoming increasingly passionate about the services they can provide to underserved communities, but equally people that working with asylum and migrant background clients also became increasingly passionate about the impact that prioritising healthcare could have for them. So I think it was quite a symbiotic relationship that began to develop between healthcare providers in Coventry and those that grassroots organisations that served asylum seekers and migrants gone down?
I think an aspect of that is the consistency of the people involved. So quite often you see very well-run projects or programs which begin to fall down when there's a turnover. What HARP did really well was maintain key personalities and key individuals throughout. So people like Angie, people who headed up the community connectors, so Angie at Coventry City Council, people who headed up the community connectors, such as Namarine, such as I'm terrible with names here.
Leona and Faranac.
Leona, Faranac. So it's Faranac that I'm trying to think of. So I'm terrible with this. They really became known figures in the communities they were working with, right? And when you become known, you become trusted. So if you look at people who've just arrived in the UK, often they get referred to one of the community connectors through friends, families, people they're sharing a house with, right? And the people they go to see are people they've been recommended to see, people who've looked after people that they know and trust. That trust is transferred. That's not something that big statutory bodies typically have. That's not something which you can generate easily. It's only done through consistent working with key individuals who've got that personality to put on a program, and that really helped too.
And I think where these, for the most part, those individuals were known to their communities before HARP started. We'll come to it later, but where they weren't always working in a health capacity, they had other profiles, whether it was around housing, whether it was around education. It means that when they come to talk about health or start trying to engage people on health, which is, as we found during the research, something that is both deeply personal, obviously, but also something that people aren't always wanting to talk about. It's not something that they're looking to prioritise. Where it's being delivered through organisations that have a strong footing and a lot of respect within the community already, you're going to get better buy-in. And so what we're going to talk about now is how that impact went across the stakeholder group. So we've sort of mentioned the participants. Oh, go on, Dan, sorry.
Can I do this bit? Is that right?
Yeah, go for it.
Yeah. Sorry, I should say. So we'd identified 4 key stakeholder groups at that early co-produce session. And what we always like to do in an evaluation is to look early at who we're trying to see impact on and see what the impact can be. And across the sort of cohort we identified 4, which were the participants themselves, which were the partners as individual organisations, which were the partnership, which is the collective of the partners, and non-partner bodies. Non-partner bodies may include sort of GP surgeries, various hospital departments, might include G4S or MITI, anyone running sort of a hotel, at a really small level, ended up including Specsavers as well. So who are these non-partner bodies that end up being influenced by the programme? But the first 3 there, participants, partners and partnership, have a direct involvement in the programme. Non-partner bodies have a less direct, and they're sort of more impacted by the programme and less buy-in themselves. And a good framework which we use for doing this is to look at the impact of on each of these groups in terms of knowledge, attitudes and behaviours. So it's at the easiest level, the sort of absolute easiest thing to do is to change the knowledge of a participant. Right? If you tell someone something and they understand it, then you've increased their knowledge on something. Right? It could logically lead, if you give someone knowledge on something, that it changes their attitudes towards something. You know, you could tell someone about it being free to use Specsavers, which gives them more confidence to go into Specsavers, and the actual act of going in is a behavioural change, right? So knowledge, attitude, behaviour. So we were tracking that across all 4 stakeholder groups here, with the aim of tracking to see behavioural changes in non-partner bodies, right? So where knowledge changes in participants was the easiest change for the programme to make, behavioural changes for non-partner bodies was seen as being the most difficult and the most aspirational. And to be honest, we didn't expect 2 and a bit years ago to be seeing much behavioural change at the non-partner body stage. As it came out at the end, there was a ton of behavioural change. So the Specsavers example is that they went from being unaware that they could offer free eye tests and prescription lenses to people with certain paperwork to actively doing that. the asylum hotels went from not providing fresh fruit and fresh vegetables to pregnant women to providing fresh fruit and fresh vegetables to pregnant women. There are lots and lots of examples like that of small and large behavioural change that took place at those top levels. And if you've got access to the report, we go into quite a lot of detail in them in case studies. But the key point on the overall bit for findings before we go into breaking it down and mindful of time is that complacency will lead to slippage. Right? This was a really successful program. It has impacted hugely across all four of those groups. I mean, we can definitely say there are people with better health or better access to health in Coventry as a result of this, right? But any complacency will lead to slippage. This needs resourcing, this needs funding, this needs people doing things. And it would be really unethical to expect the community connectors to continue to deliver this kind of work at this level without support and resource to do that.
So that said, we're now going to quickly run through findings and recommendations that we had at each of those sort of higher levels. So the partner, go back, the partners, the partnership, and then the non-partner bodies. So for the partners, so when we're talking about partners, we're talking about the community organisations that were funded to run the programme. So the ones that had the community connectors and were delivering interventions to improve access to healthcare, removing barriers to healthcare for asylum seekers and refugees within Coventry. So over the course of the programme, I think I've alluded to it a little bit, but what came out incredibly strongly was that it hadn't been something that any of these organisations had considered themselves a provider for previously. So none of the community connectors or their organisations felt that they had health as a core engagement strand beforehand. That's not to say that they weren't coming across issues relating to health, but it wasn't something that they were either thinking they were massively contributing to or weren't seeing it as a key part of their work. With this programme, obviously that changed. They had funding to specifically address issues of health. That doesn't mean that they were delivering healthcare themselves, obviously, but it meant that they were prioritising it. They were focusing on making sure their clients had GPs. They were making sure that their clients were engaging with the NHS app, checking in with things like they knew how to access primary healthcare without necessarily just going to A&E. All those sorts of things became a focus for them. As a result of that focus, what then sort of snowballed and happened was that these organisations went on to find ways that they could have in-house health offers. That looked like finding free screening services, particularly for things like tuberculosis, that could come into these organisations and deliver the healthcare on site. Those two things went quite closely together and also were something that the partners really came to value. So particularly where in the past they had been made aware of clients having really severe health concerns, but largely at a late stage of that health concern when things were sort of escalating towards an emergency situation. By having it as a focus and talking to people about their health early on and getting people to raise their concerns really early on, they were catching things like cancer, they were catching things like glaucoma. There were lots of interventions that they were seeing as a result of their intervention or their encouragement for people to find intervention. So obviously from that, our recommendation would be that that should be maintained. So there should be a continued focus by these organisations on engaging with health, and that there should be a focus on making sure that they can keep bringing in those external services to help provide support in-house, be it eye tests, hearing tests, what have you. A lot of organisations, or there's a lot of free screening programmes, and that once they had the awareness of them, it was really easy to get them back into and fight them again.
Thank you. And the bottom two here, continue building professional confidence and champion and disseminating best practice, are closely linked, but there is a distinction between them. The first one, around continue building professional confidence, really recognises that a lot of the people who are providing the frontline services here, the ones which Emily talked about there, which help people to catch glaucoma or cancer at earlier stages, or even delivering sort of ESOL for first aid and so on, didn't see themselves as highly skilled practitioners. This was a project which they were excited about and sort of valuing, but they didn't often see the value in themselves. Right? They didn't see that you sometimes get so bogged down in the work you're delivering, the work you're doing, you don't see the importance of it or the novel nature of it. So we felt a really important recommendation was to continue building that professional confidence, to have the people who are delivering this who are experts, who there are people in Coventry who know more about the needs of Iranian asylum seekers, the health needs of Iranian asylum seekers and refugees than anyone else, right? There are whole PhDs out there which people could be writing about this stuff, but it's their everyday job and they don't recognise it is that real expertise. So to continue building that professional confidence and get people to start formalising what they do, and at the same time, along with that confidence, you can start to really champion, normalise the dissemination of best practice, right? So a challenge with lots of programs like this is that they'll be happening sometimes in 2 or 3 places across the country at the same time. And there's a real inefficiency there in everyone reinventing the wheel together. So if you're running this program in Coventry and someone's running the same program in Leicester and someone's running the same program in Tower Hamlets in London, I would suspect there's going to be a lot of commonality. Actually, what we need to be doing as interested parties is to be formalising how we record best practice, how we share it, and making sure that the people who need to read it, because there is best practice there, and it's a real efficiency to do that.
And just before we move on as well, around that championing, disseminating, and building that confidence, it's got such a dual nature. So it's not just that the partners were having their confidence built, but as a result of them spending time with healthcare practitioners that were looking for support, particularly with some of their asylum seeking clients around eligibilities, but also some of the wider myriad. So I know that HDCR are looking a lot at the broader issues, right, that are affecting health. So for example, if there was an example of on a cancer ward in a hospital around Coventry, they had someone who was coming in receiving cancer treatment. It was necessary for their health, but they were also needing support with housing and a myriad of other issues that they don't have the time or facilities to deal with in their own role. But it's obviously deeply upsetting if you have a patient that you're caring for and you know that they need support in other areas. So with HARP, what began to be created, and we'll talk about it in a moment, was this network that healthcare professionals could lean on for that support that their clients needed. And actually, for the community connectors, having that confidence in those settings to say, yes, I can help, was massive and made such a big impact on the overall quality of care that people were receiving. Leading on from that, recommendations for this partnership were a part of what Dan was referring to earlier around needing to make sure that these services continue and that their funding is expanded so that they can keep doing what they're doing. I think, again, lots of the services that we were speaking to by the end of the project, in some of the qualitative data, it was really moving. Some of the things they were saying around like not really knowing how they'd managed to function before HARP existed, and that now it did exist, they would be really sad to lose it as a support for their clients and for themselves. So that's obviously everyone.
Standardizing data collection and reporting is a key finding here, but again, it's not a new one. This is something which we tend to see in big, messy, multi-stakeholder projects, right? So by the sort of midpoint of the project, we had managed to get standardized data collection and reporting, and by that we mean when you're recording country of origin, it's Iran, not Iranian, that kind of thing, right? So when you're recording first language, it's done in a set way with drop down boxes, because otherwise you can end up with a very messy data set where boxes overlap and you're kind of making best guesses as to how many 18 to 24-year-olds you've got and how many 20 to 30-year-olds you've got. So you need to have these bits standardized. That's not a new finding, but it's some good practice to get into these kind of programs because it makes it much better for reporting towards the end.
And given the timing of this report, which was sort of written in September, end of September 2025 and presented in October 2025, at the time, as I'm sure most of you will remember, there was very loud conversations in politics and the media around hotel provision for asylum seekers. So one of the key findings for the HARP beneficiaries was that having healthcare provision brought into the hotels was really effective as a first step in addressing health concerns early on, particularly around some of the maternity work, and vaccinations were found to be really successful when they went to the hotels. Now, obviously, that was a great finding for the programme and was really effective for the programme. However, at the time, as I was saying, there was a lot of conversations around what those hotels were going to look like. Government wanting to close the hotels, local authorities not really being clear on how or when that would happen and what support they were going to get. But it became very clear that if that was going to be taken forwards, was there a way that that centralised or close to the community offer could be recreated? It remained to be seen at that point. It's still, I think, as far as I'm aware, remains to be seen now. I know that the government plans are still by the end of 2029 to have closed all asylum hotels, but that's such a long way in the future. And it is a useful point for us now to reflect on, that as of September and October, that was a really key point, and that it's something that needs to be checked in on, even now as we move into 2026. Dan, you look like you wanted to jump in. You good?
No, I was going to say we're going to run out of time.
Sure. Okay, and quickly moving on to findings and recommendations for the non-partner bodies. So I'm going to be really quick now. Mainstreaming refugee and asylum seeker inclusion. Now, what we didn't want this to be taken away to mean is that, okay, well, now we know that there's ways to include refugees and asylum seekers within mainstream provision, we should just do that. That's not quite what we're getting at. What we're saying is that, along with the second recommendation in green, is that we should continue to use those community resources and expertise, and pairing together things like healthcare provision that's already standardised, NHS healthcare provision, but making sure they're linked into some of these community networks that already know about how to provide that wraparound holistic care. A lot of what the HARP team talked about and felt strongly about was holistic care. So making sure that they could provide more than just a one-off intervention for someone in desperate need. It was more about how do we take that person and make sure that we can look after their health in the longer term. And Dan, do you want to do the last one in the final minute?
Just very quickly, this is the last proper slide. So a bit like the recommendation around hotels, 6 months is a long time, and we're not really sure what's happened with this recommendation since, but we were very clear that the health needs around recently arrived migrant populations in Coventry and surrounding areas are distinct. There are intersectionalities which impact those groups disproportionately, and that we recommend as a result there's a dedicated migrant health subgroup set up to make sure that those are recognised and addressed. The last slide, when we get to it, is our contact details. Please do, if you've got anything that you want to discuss privately or any questions you've got for us that you don't want to discuss in the sort of upcoming chat, do get in touch with both of us. If you email both of us, we will come back to you. And you know, I love talking about this. Emily loves talking about this, so we're more than happy to engage. The report itself is intellectual property of Coventry City Council, but we can signpost you to the people at Coventry City Council who may be able to make it available to you.
Thank you again to our presenters. If you have any questions that you would like to reach out to presenters, their email addresses are in the chat. Please also keep an eye on your inbox. You will receive information for the next webinar from Coventry HDRC in due time. So thank you again and have a great day, everyone. See you next time.
Thank you, everyone. Cheers.